Hello, everyone. So basically, we're going to go through some cases today. Pediatric medicine is a bit of a minefield because everything you've learned so far in year 4 about adult medicine doesn't really apply in pediatric world. So what I've done is I've made some cases and to basically illustrate that. And I've also basically done a bit of how to take a history and what a normal finding is. Okay, so history examination. So first of all, there's a lot of information on one slide, which I don't like, but it's kind of just to illustrate the point. When you're seeing a child, quite a young child, especially a baby, you need to kind of have a whole picture of how they've been developing. Okay, so in terms of this presentation or this history, we need to first of all take it down into bits. So the first thing is, obviously you want to know the history of presenting a complaint. You want to know what's been going on for so long and how this has changed. And your normal thing like, when did this first start? How did this change? Any other symptoms? Then you want to know any past medical history. Does this patient have any allergies, any asthma, anything that is significant to their history of presenting complaint? And then you do something which you wouldn't normally do in a 90-year-old man, is that you ask them about their birth history. So obviously you're not going to ask them, but you'll ask the parents. So when you ask about their pregnancy, some things that happen in pregnancy can really affect how their breathing works. So you ask them about any complications, any medications that the mother had to take before or after, such as antibiotics especially. You ask about if the mother smoked or drank during the pregnancy. You ask if they had any antenatal screenings or diagnoses, which possibly could point you to a certain picture you're looking at. And also some babies, when they're born, their lungs aren't developed yet because they're premature. So they get put on a ventilator. And that's really important to know because obviously being put on a ventilator when from the second you're born is a risk factor for having respiratory conditions further down the line. And then, of course, there's how is delivery. So was delivery a C-section or normal vaginal delivery? So the reason we worry about that is in a C-section, what is the reason they had a C-section? Was it an emergency section? Was this baby premature? Did it have any problems breathing when it was born? Did there anything that would affect their breathing now? So these are why these things are very important, especially to someone presenting with any breathing difficulties. There's many diseases which can affect your breathing, such as ones we'll go over. So you need to know if they're covered for that. Ask about immunizations or how many they've had. Most babies, when they're developing, have these red books that have the immunizations written in them and also their centiles. So you can see how they're developing relative to what is normal. So if they're in the 95th percentile, means they're obviously way bigger than the normal would be, or are they off the lower 20% or 5%? So that gives you an idea of how they're developing relative to what is normal. And the red book, thanks to Nish, is going digital, but very slowly. From now, I think they still have the red book. Then you want to know about development. Obviously, this is going to take a while to do, but this is for another time. But you break development down into 4 main structures. You ask about gross motor, which is basically like how their movements are. Fine motor and vision, such as very specific movements like seeing and hearing. And then speech and language, and social emotional behavior. So we'll go for that another time, but that's all able to know how they're developing and is there anything that's causing them to develop more slowly. You then ask them how they're feeding at the time. What is the normal for them? Have they been feeding less? Have they been going to the toilet less? Are they having wet nappies? Is they having less wet nappies? Is this baby dehydrated? That's what you want to know from those 2 questions. You want to know that on any medication, that's normal, any allergies, and then are the parents consanguineous? Does anyone know what that means? Consanguineous. If anyone want to write in the chat what they know what that means. Yeah, exactly. Are these patients brother and sister, or the parents? And you get a laugh out of it, and the parents are like, oh no, but it's very important to ask because obviously if they're reduced gene pool, more likely to go on to have genetic deformities in the child, which could be reason why they're presenting as such. It is a very awkward question, but the way I ask it is, oh yeah, so how would you phrase it? Thanks, Nish. Yeah, so how would you phrase it? That sort of question. Just maybe type on in the chat how you would ask, are you brother and sister? Or you could ask, are you brother and sister? So okay, so basically the way I do it is basically there's a list of questions I have to ask. I'm sorry, these things may sound ridiculous, but we have to check. Are you related to your partner in any way? And they'll be like, no, very quickly. And that takes the awkward out of this. You basically normalize it and be like, we ask this to everyone, okay? It's the same thing you do for drugs. Like, and this may seem ridiculous, but we need to ask this to everyone. Have you taken any heroin, any cocaine, any marijuana recently? You sort of normalize it. So that's how I do it. But people have their different means. Okay, social history. Won't go for this.
Can I just...
Go on,
Sorry, can I just mention something really quickly?
Go on.
You'll notice loads of different types of family dynamics when you get onto pediatrics. So try and rephrase that question in accordance to the family dynamic.
Mm-hmm.
If there is, so like if they're married, use husband or wife. If they're not married, remember to use partner. Like just
I always use partner. I always use partner. I think partner you can't go wrong because again it's like completely non-gender everything. Just be like partner. Partner can be a friend or a boyfriend or girlfriend or wife or husband and they say no, I haven't got a partner. So it's very easy.
Partner is a great word. The only a place where partner doesn't work is if they're not together anymore, and then you're going to have to be like the child's father or the child's mother. So just keep it in mind.
Very good point. Okay, so social history here, won't go into that much. Basically asking about are they single parent, any socioeconomic factors, any social care is very important. Asking a social care worker. Something that was always reminded to me when I took a history, is there any social care input? Because obviously, you want to make sure this child is safe. And then a few other things, pets, travel, childcare, school. Okay, so RESP exam. Quickly, it's not very difficult to do this when you're over a presentation, but basically you want to take a general examination. You want to know their weight, the height, temperature, the color they are. So you want to make sure there's no cyanosis. Are they moving okay, or are they quite floppy and still? Then respiratory exam, more specific. You take the respiratory rate, and then you look for certain signs. So sinus we already talked about. Finger clubbing, it's just something that they put in there, but basically say cyanosis, the bigger one. Nasal flaring, intercostal, subcostal recession, we're going to talk about in a second. Chest shape, any kyphosis or change in the chest shape could be reasons why they're having respiratory difficulties. Then you listen and auscultate, which are the same thing, but I put them there both. Good. So, anyone know what these are? Oh no, are they not? Oh, they haven't. They're not. Sorry, they're not come up as movement. Basically, right. So this one here on the far left, their nose is moving out and up. But I'll talk you through this. Basically, this is meant to show nasal flaring, because the nose sort of like that. So they're really trying to breathe in through their nose, and you tend to see that more in babies. Here, this is intercostal recession. So as you can see, you can see the outlines of their ribs. That's the intercostal muscles being used to really help with their breathing. And then you could also sometimes see subcostal recession, which is the diaphragm. So you see their tummies like come in and out like that. And there's a video link here. If you want to click on it afterwards, I won't do it now because I'm scared that it will come off the screen. But if you click on that now, I've linked a video showing subcostal recession as well. And here, if it was moving, you're able to see basically something called tracheal tug. And that's basically the trachea just being moved out like this. So you hear about tracheal deviation, which is different. Tracheal tug is basically when the trachea is being moved as the muscles are contracting to open it and close it. Not open and close it, but basically keep it patent and keep the air coming in. And I haven't seen it, but it's one of the signs showing increased worker breathing, and it's something to look out for. And they'll always ask you on the ward, did they show any signs of increased worker breathing? And these are the things to talk about. So intercostal, subcostal recession, nasal flaring, tracheal tug are the main four. And sometimes they'll also talk about head bobbing. Does anyone know what I mean by head bobbing? Anyone in the chat want to say what? If I said the child had head bobbing? It's kind of it's not something you see all the time. Anyone know? Don't worry if not. Oh, someone said that. Yes, good. So you normally see it when the baby is breastfeeding. So they're breastfeeding, and then obviously they're struggling to feed at the same time as breathe. So their head is moving in and out as it comes on, as they're trying to increase the work of breathing. So you sort of see their head bobbing back and forward. But it's not a massive sign. These are the bigger ones: nasal flaring, intercostal cycloprocession, and tracheal tug. Okay, so click on the link in your own time because it's very good, and it shows you which is. So this is the first case. So the way I would normally do this is I would ask someone to take a history, but I think for time purposes, we'll just go through it. So this is a 6-year-old boy, and they come to A&E with the mother, and they're making strange noises. Okay, so after taking a history, you find they have no cough, and they have not been drinking, and they have been unable to keep anything down. The baby feels hot and clammy, and there's a soft noise like a whisper when he's breathing in the last few hours. He has not said a word since this morning, and he's been very upset and clingy. So good thing is, like, what's their normal? So I would have said, the mother would have said, their normal is their happy-go-lucky child, constantly babbling about. But today they haven't said a word, and they're very upset and clingy. Very important that will go to the mother. They're upset. The patient is also, the baby you can see is also drooling. So go back here a second as well. So 6-year-old boy making strange noises, and this is the full case. So anyone have like any ideas what they think could be going on, or maybe they want to suggest something that they would like to do? Either or. Write in the chat. Go on, take off your mic. Happy with anything. There's no wrong answers, by the way. This is quite niche stuff. Anyone know what they think could be happening? Okay, so epiglottitis. I like that. Anyone else think of anything else this could be, or would like to rule out? So, okay, good. So croup, epiglottitis. I like both of those. So let's go through quickly what test you would like to do as well. So what test would anyone like to do on this person who's come in? They look hot and clammy, slightly noisy breathing. We're thinking possibly this could be epiglottitis or croup. Anything they really like to do? No one answers again. Good. So you want to know what their option stats are. Always good. So basically, what you're saying to me is like bedside test. Always think bedside. That's good. So like take the respiratory exam. Good. Temperature. You want to make sure this patient isn't septic, or maybe they are septic. Good. Good question. I'm going to go through that in a second. Basically, yes, you do. You do exactly the same thing you would do in an adult. It's just your management changes depending on the readings are different depending on the patient. So, for example, basically the heart rate is allowed to be higher in children, but it goes down the older they get. I don't know the exact ranges. Normally the pediatric consultants have a little card which has all the ranges for them because they forget themselves, and their heart rate is allowed to be higher basically because their parasympathetic drive increases as they get older, so therefore your blood pressure and your heart rate slowly come down. Okay, so your heart rate is allowed to be higher, but you do the SEPSIS 6, which is here. So good O2 sats, ABG, urine output, blood pressure, fluids. Apart from fluids are a bit different in children, which we'll do for another time. But fluids are quite. You don't want to be giving 500 ml stat to a child who's very small and has a different sort of volume dependent adult. So that does change, but your basic structure doesn't change. So you do your temperature. You do take 3, give 3, and this is what we've done here. So would you examine this child? Would you lie them down, or how would you lie them? Who go on.
I was just going to jump in and say something for exams again. Something people worry about. All of the pediatric observations are given to you in the exam. They'll be on your normal value sheet. So please, for the love of God, do not spend time learning those.
Consultants have them on a card.
Yeah.
That
like nobody knows them.
Yeah. But knowing what is grossly bad probably is not a bad thing to know. So good. So Anya says no, that they're not examining the child. Okay. So before we go into that, I want to quickly talk about Stridor and not lying down. Okay, good. So I'll quickly talk about Stridor because you mentioned croup and epiglottitis. So these are both causes of Stridor, Basically, anything that's going to cause an obstruction to the upper airway, you're going to hear different types of sounds. The stridor is a loud, harsh, high-pitched inspiratory sound due to partial upper airway obstruction. And then basically, the degree of obstruction is assessed by seeing whether there's any increased work of breathing. So what we talked about before, like chest retraction, increase in subcostal, intercostal resection, and also stridor. So are they crying at rest, or is it when is it biphasic, or both the time? Is it when they're lying down completely happy, or is it when they're really trying to breathe? So that's how you can differentiate how large the obstruction is. And we talked about the signs of respiratory distress already. So, but these are them again. So grunting, hard exhalation, stridor, which is different. This is inspiratory. So grunting is when they're breathing out like, and stridor is when they're breathing in. Okay. Nasal flaring is what we talked about, and the head nodding when they're feeding, and obviously the tachypnea if they have increased respiratory rate. These are all the things to look out with increased work of breathing. Okay. In pediatrics, they group patients and their signs based into this like traffic light system, which they don't use all the time, but I think it's good to know. Definitely do not learn it, but I think it's good to know what is high risk and what is low risk. Obviously, for some reason, the low risk hasn't come up, but your high risk is going to be anything which is very severe increased work of breathing. And those are things we talked about. Grunting, very high respiratory rate, which is above 60, but it will change depending how old they are. As you can see, 6 to 12 months is above 50, but when you get to above 12 months, it's above 40, so it does change. SATs less than 95 is an amber, and cracks in the chest. Basically, anything which is showing that this patient could have an infection or has in lower oxygen SATs. The high risk is when they're really struggling to breathe, when they're really having to use all their muscles to open up their airways, and like subcostal and intercostal recession, grunting, and very high respiratory rate. Okay, good. So back to our case. We have examined them, but we haven't looked in their airway. And it was a bit of a trick question. So you basically do not want to look in their airway, and we'll talk about that in a second. So you do examine them, and auscultation, there's no wheeze, but it is an inspiratory whispery noise heard inhalation, so stridor. There's no crackles, so basically no signs of infection, and there's no signs of respiratory distress. So this patient doesn't have any signs that increase work of breathing. We have not looked in the mouth because that is bad. And this is acute epiglottitis, and it's caused most likely by Haemophilus influenza B, which is actually not common anymore. Does anyone know why it's not that common anymore to get acute epiglottitis, or why it shouldn't be? Oh, it's written. Okay, yeah, exactly. It's very rare now because all babies should get vaccinated for Haemophilus influenza B. I did know my vaccinations for about a day, but I've forgotten them. I'm pretty certain it's one of the first ones they get. But again, we'll talk about vaccinations another time. But basically, remember that it's acute epiglottitis is caused by Haemophilus influenza B, but there's a vaccination against it. There's an intense epiglottitis, which is what's causing that stridor sound. And these patients are ill. They are septic. And that's why you want to do your SEPSIS 6, your septic screen. And it's a very quick onset. They're fine. And then the next minute, they're septic. They're very ill. The features they normally have, no cough, upper respiratory, so no cough. They're unable to drink because their airway is so closed off. And they're drooling because that saliva is going nowhere because they can't swallow. They have a very high fever, and they have this soft stridor noise, which is different to croup. And we'll talk about that in a second. But croup is definitely diagnosed here, because they're very ill and they have a stridor sound. You want to make sure you're not missing that. But this is the one thing. This is the one thing you don't want to be missing out on, because this is their septicemic and they can really fall off the cliff unless they're properly seen to. Exactly, Claudia. If you think about that, the fact they can't even drink and they're drooling, that airway is completely closed off. If you start poking your finger around there and then try and look inside or moving their head from side to side or moving up and down, you're going to close the airway even more, and their SATs could just fall and they could really stop. Basically, it's a never event. You shouldn't be examining the throat or mouth of anyone of epiglottitis, and for that exact reason, that it's going to increase the obstruction that is already there. And I don't think it's about just looking, ask them to open. I even asked them to open their mouth, could close off that airway. So you really just tell them to relax, or if they can, and keep them calm and not stressed, and you get it to someone more senior more quickly. Okay, so management. Let's talk about that. So management. First of all, they're going to need a senior anaesthetist because they may need to be intubated because their airway just isn't working. Their airway needs to be made patent, and they need a senior anaesthetist immediately. ENT possibly as well. These patients are very ill. They're going to need to go to ITU, most likely because they need to be intubated. We use nebulized adrenaline, and then after that intubation, I'm not going to lie to you, I can't remember why we use nebulized adrenaline. I think it's just to help keep the airway open, and basically it's the same as someone who's like anaphylactic. You want to keep that airway open. You're then going to cover them for the sepsis 6. You're going to take cultures and give broad spectrum antibiotics. Most likely in kids is cefotaxime. That's what they use in kids all the time, which is quite nice because you only need to remember one drug really for antibiotics. Anything they don't know about, broad spectrum drug, cefotaxime is the best. And you're only going to do your bloods once airway is secure. That's really important. There's no point doing works up for blood cultures and all this stuff until the airway is secure. So really that isn't really a 6. That's just me saying that you're not going to do 5 or until basically you make sure that airway is secure properly, because that obstruction is very likely. And then anyone in contact, you give rifampicin as prophylaxis to basically prevent anyone from getting that. Okay. Does anyone have any questions on acute epiglottitis or anything I've said so far before we move on to our next case? I think it's the next case. This is something you probably won't see. I never saw it, but it was always something that they had up on their list of something that it could be. Because it's something you just can't miss, because these patients can be seriously ill. Okay, cool. So number 2, 2-year-old, brought in mum and dad, very worried, been a bit worse for wear, now making a strange noise. Okay, so let's go on to the noisiest child, query dog. All right, so they've been making a barking noise at night. Previously, they've been very snotty and sneezy for the past few days. Now they're very hot and clammy. No significant past medical history when you question them. On no medication, no drug history, and they had no significant family history. So, anyone want to guess? Oh no, I don't want to ask that. What would people like to do next? Any other questions they'd like to ask? Let's do it that way. Let's make it more interactive. What would people like to ask next? Next. No wrong answers. Nice, I love that. Eating and drinking, exactly. So you want to know if they're epiglottitis, are they being able to keep anything down? Also, if they're eating and drinking, is a good idea to know if they're dehydrated or not. That could change your management further down the line. Does this patient need resuscitation with fluids, depending on their observations? Very good. Cool. Right. Does anyone think they know what this could be or what is most likely to be? Croup? Yeah. Croup. They're never going to, no patient, no mothers or father or anyone who's looking after a child is ever going to come up to you and say, my child sounds like a dog. But believe me, they once you hear it, it's very recognizable. So before that, he is making barking like noises when he coughs, but he has no signs of respiratory distress. His temperature is high, it's above 38. After that, did he examine the throat? Probably not, because you can't be certain this patient hasn't got epiglottitis. So you can see, compared to the last patient, that they still have things like hot and clammy. They've got stridor. There's no reason why this patient can't have epiglottitis. Okay. Other investigations. Let's talk about that. So first of all, croup. This is basically an upper respiratory tract infection, most commonly seen in infants and toddlers. It's also known as laryngotracheobronchitis. It's most commonly caused by the parainfluenza virus, and it's most commonly seen from 6 months to 6 years, but majority of them are age 2 or around there. Okay. It's got a seal-like cough, barking. They have a fever, coryzal symptoms normally beforehand, and it gets worse at night because when they lie down, it basically causes more of the obstruction. So it causes more of the problems. And you basically grade it. So this is how you grade its severity. So they don't use this, by the way, but this is how, from when I was on the Royal Free, but it's something that to be aware of. So if it's mild, sometimes they get a barking cough, but they don't have any stridor really at rest. They have no increased work of breathing, and they're very happy, and they're prepared to eat, drink, and play. When it's more moderate, they get this frequent barking cough, but they're stridor at rest, and there are signs of increased work of breathing, but the child can still be like placated, and it's very interested in its surroundings, so it's not very distressed. When it's severe, basically stridor at rest, increased work of breathing, and they look terrible, agitated, distressed, because they're getting hypoxic. They have hypoxemia, and they're having very increased respiratory rate with more severe obstruction symptoms. So that's how you grade it. Does anyone know how we would treat croup? Like what every patient should be getting if you think they have croup, or if croup is the most likely diagnosis? And anyone know what we give for someone with croup? Dexamethasone, very good. Fluids, okay, we'll talk about that in a sec. But dexamethasone, every patient should be getting that. Doesn't matter about their severity. I think it's here, the next one. So yeah, doesn't matter about their severity. Every patient should get oral dex. Basically helped with the obstruction. That's what every patient gets if they think it's croup. Any child's got moderate or severe presentation. Basically, any child that has increased work of breathing needs to be admitted. Other features which would prompt admission, if they're less than 6 months, even if they haven't got increased work of breathing, if they're known upper airway abnormalities such as Down syndrome, then they are more likely to become obstructed later down, so they need to be admitted. And if you're not really sure, basically, is this epiglottitis? Emergency treatment would be high flow oxygen and nebulized adrenaline. Fluids is basically, I think that would depend on patient to patient case. I think that in terms of this patient, if they're quite happy and you basically do, they don't tend to do blood pressure in kids because they kind of be all over the place, but you basically do it based on like your fluid status examination. So if they, how many wet nappies they had, the color of their stool, do they have diarrhea. You also look at their skull, if they have depressed skull. Sometimes when they're very dehydrated, I can't remember the exact word it is for it, but they have a depression of one of their plates. Oh, help me out, Anush, you're still here. I can't remember what that's called.
Sunken fontanelles.
Yeah. Was it fontanelles? Sunken, that's it. Sunken fontanelles.
Fontanelles, yeah.
Nice. So basically, sunken fontanelle is basically when you can see like a little dip in the skull. So yeah, so for all that, you would tend to give fluids more, but with most children, they don't really need it. They're basically if they're dehydrated or not. Cool. So, but what is the most common cause of stridor seen in children? Bonus mark for anyone who knows this. I didn't personally. Foreign body? Not quite. It's definitely up there. The flu? Not quite yet. It's actually Laryngomalacia. I can't believe you guys didn't know that. Again, this is something that was just taught on the wards. This is basically congenital stridor. So it's a congenital abnormality of the larynx. It makes them more likely to get stridor, and they're actually fine. But they need to make sure that it's yeah. This is just a little bit of knowledge. Basically, that's the most common cause, and they like to ask you that on the wards. But as I love that you said foreign objects, definitely never forget that. Kids love putting things in their mouth. They get coughing, choking, vomiting, or stridor, and that would definitely be something to look at. Flu, I'm not sure that does cause stridor. Parainfluenza technically is the flu. So that will cause croup, but hemophilus influenza. So yeah, but the foreign objects definitely something to always be aware of. So I made this sort of slide, which basically compares the two. So cough, no drool, but drool, no cough is basically the thing I would take away from it. In epiglottitis, they're toxic. They're really ill. They're, they can't swallow. Do not lie the child down. Make sure the airway is secure by intubating, and don't examine the throat, as this may precipitate obstruction. They need IV antibiotics. Croup, grade them. Depending on their grade, they get admitted. Every patient gets a single dose of dexamethasone or budenazide. Any severe signs, such as cyanosis or sternal retraction or increased respiratory rate, then they get nebulized adrenaline, and then ITU, if not evolving, then could this be bacterial tracheitis, epiglottitis? Okay, nice. Oh, and a little thing here: oxygen, dexamethasone, adrenaline. Cool. Anyone got any questions between croup and epiglottitis? I put these two together because they're the two that are like the ones you don't want to miss, and also the ones you want to escalate quite quickly. Got a couple more cases so we can run through them. Everyone happy? Cool. Just pop your questions in the chat and I will deal with them as I go. So everyone loves Pokemon. This is Wheezing. Wheeze King, I don't know which one it is, but Wheezing. Let's talk about Wheezing now. So case number 3. 2-year-old has been a bit snivelly. Parents worried about breathing. This is the whole thing. So for the last few days, they had quite coryzal symptoms, coughing and sneezing, but they're now making a wheezing sound. But that's never happened before. Mum did smoke during pregnancy, now smokes around the house. There is a significant family history on the mum's side of asthma and atopy, and on examination, you hear this. So, on examination, no signs of respiratory distress. Sorry, talking for a long time. Polyphonic wheeze, which is bilateral. Respiratory is bilateral. Sats at 93%, temperature 36, respiratory rate 20. Okay, what does everyone think? First of all, are we worried about this patient? Simple yes or no, maybe, I don't know. Yes, okay. Anyone not worried about this patient? 93% sats. Okay, nice. Anyone not worried about this patient? So I'm guessing we're all worried or we all don't know. Okay, so basically, I should have asked what you guys think this is. I'm sorry about that. But this is preschool wheeze. Okay, so no patients, no babies should really be diagnosed with asthma until they're a lot older. Preschool wheeze is basically, there's 2 types. There's episodic viral wheeze. This only occurs after an URTI, a respiratory tract infection. And normally they have a history of maternal smoking during pregnancy or after pregnancy, and that's the main risk factor. There can be atopy, but not always. The main treatment for this, it depends on their age. If they're above 5, then you can give corticosteroid. If they're less than 5, then montelukast. But there's also multi-trigger wheeze. Basically, this is when they have like exercise, allergens, cigarettes, anything that's going to basically trigger them all the time. Basically, for that, they're going to need an asthmatic treatment, which is inhaled steroids or montelukast. Okay, so asthma can only be diagnosed with 6 years or above. Anyone below that can't be diagnosed with asthma. Really important to remember. I saw a lot of babies and who are 4 or 3 who basically been put on an asthma stamp on them forever, and they were on inhalers and they just hadn't any symptoms because they had a bit of preschool wheeze when they're younger. It's the most common chronic disease in children. The risk factors are basically mostly male. I'm just going to get some water. Be 1 second. Right, I'm back. Basically, don't really look into this diagnostic criteria. I put this up here for interest. Don't need to know it. It's just important to know the difference between asthma and preschool wheeze. Okay, less than 6, they come in with a wheeze and they've got a history of cigarettes and smoking. It's this preschool wheeze. You then get treated depending on their history. If their history of like a one-off episode, we're going to give a one-off dose of corticosteroid or montelukast. If they're above, if they got a lot of different triggers such as allergens and smoking and constant coming on, then they basically need to get treated with an asthma treatment. And the majority of time, they get to 6 and they just get slapped with their asthma diagnosis because they carry on needing their inhaler. So on this patient, you examined them. Oh, and we'll talk about the 93% stats in a minute, Claudia. I'm just going to get to that in a second. So, yes, remember to check passive smoking. Definitely asked about the mother. Did they smoke during pregnancy or are they smoking now? So on examination, no clawing. you look at the ears, nose, and throat for any signs of allergic rhinitis. You ask, do they have any eczema? This is basically all their pulmonary history. They have any respiratory wheeze, and are you basically looking if they have any signs of respiratory failure? The investigations, only children above 5 can have a PEFR and spirometry. So less than 5, obviously they just get diagnosed with preschool wheeze most of the time. Go on symptoms and SATs. So good. So less than 95%, really is not good. So, and they're having symptoms, you're going to treat them. Some kids get chest x-rays, most don't. Take allergen skin tests to find out if there are any triggers, and you give a trial of salbutamol. And this is a bit over the top, but I'm afraid you do need to know this. So I'm just going to talk you through it quite slowly, but also not in a lot of detail, because I think it's something you need to go away and just learn. I wrote it out on a blackboard, and the reason you need to learn this is that this is something they test quite a lot. It's asthma in kids, because it's quite easy to test, because it depending on their SATs is really the thing they go on. So basically, if their SATs are above 95% in mild, they're kind of okay. You can sort of treat them acutely with salbutamol. This is for asthma, by the way. Sorry, I should make this out. This is basically for kids who are above 6 years old and have been treated with asthma, or having asthmatic attack. This is an acute setting. What we're talking about before was sort of like your chronic management of the patient who have a preschool wheeze or asthma. This is now like their acute management, like the asthmatic attacks. Basically, go through your own time, but this is depending on their SATs. It's majority from mild, moderate, severe. Life-threatening is, remember, your silent chest, the whole respiratory rate, fatigue, basically having increased CO2 retention, hypercapnia. This is what's going to get them respiratory failure. And then you basically need to increase the amount of stuff you're giving. But do learn this. Not now, close to exams. Learn it, because it does come up. And this is what they use. So this is the guidelines that they use. I think these are the BTS guidelines. These are the ones that we were told by that they use, not the NICE. They use BTS, UCL. But this does come up a lot. So every year they tell us that everyone says, which one do I learn? Which one do I don't learn? Do I learn it? What's the point of learning it? You do need to learn it. And they told us that they use BTS. We asked so many times. So learn the BTS guidelines. These are the ones you need to learn. It's not that much to learn. Just go through it. Basically, it depends on their age. If they're less than 5, then they should be on montelukast, a leukotriene receptor antagonist. If they're above 5, then they can be on inhaled corticosteroid. And then you add on stuff depending on how old they are. So just go for it. But BTS guidelines for asthma is what you need to know. Has anyone got any questions of that? Sorry, the reason this may come across like information overload. It's quite difficult to talk over a slide. Kind of need to just go away and learn it. But I think those 2 slides, this one and this one, if you stick to these 2, you'll be absolutely fine. Okay? And even though this one's a lot of information, but it's definitely worth learning. Is everyone okay with that? Anyone got any questions about that before we move on? Okay, so good. Thanks, Anush. Nice. So basically, it's what we talked about already. So inhaled steroids. If anyone's on inhaled steroids, you're going to monitor their growth, because it can cause adrenal suppression and restricted growth. Whilst this is true, catch-up will occur though, so don't need to worry about it too much. But always remember, anyone who's stopped taking their steroids for any reason, that could cause an adrenal deficiency, or in other words, an Addisonian crisis. Remember, vomiting, abdominal pain, and decreasing consciousness is something you need to be aware of. But just be, back of your mind. Anyone's on steroids who stopped taking the steroids, could this be adrenal insufficiency? Okay, so same child we saw before, but now they look very pale. They're sinking into their chair. They look very fatigued. They're agitated. You listen to their chest. It's silent. And even though I said we don't do it on younger kids, I think this one was 6, wasn't it? Okay, their PFR is now less than 33%. Okay, who is now worried? Like, really worried? Or is everyone kind of fine with it? Good. Okay, nice. So I'm just going to quickly go back to what we had before. Okay. So this is what we had before. No signs of respiratory distress. There was a wheeze. So that's 93%, so less than 95, but not terrible, but still worrying. The respiratory rate was fine, and the temperature was fine. Now, I'll go forward. Now, fatigued, increased respiratory effort, really not able to breathe as much as they were before. They're agitated. I know stick still because they literally can't breathe, and their chest is silent. And then ignore the last bit. I don't like that. Basically, the rest of it, they're fatigued, silent chest. Good. This is an emergency. The most reliable sign for assessing severity is option SATS. Okay. All children with an exacerbation asthma should have a 3-day course of PRED, regardless of severity. And basically, what I've done here is I've grouped it in depending on what it is. So it's moderate. It's all about it's just a wheeze. Their stats between 92 and 95%. And the way you treat that is you give a 10 puffs of SABA and then repeat after 15-20 minutes, and then you discharge a 3-day course of prednisolone. Okay. And this is what this person probably has: severe, life-threatening. And I tried to make an acronym for it, but you give oxygen, SABA nebs, EPA nebs. You give them back to back. You're going to give IV salbutamol with IV hydrocortisone and IV magnesium sulfate. But all this you won't be doing as an FY1. It'll be done in ITU. And then basically this is all for the patients who are fatigued, if they're deteriorating, if they're spiritually distressed. Okay. So last case. Okay. So 3-month-old, sniffly with a dry cough and is breathing strangely. So they were born prematurely at 36 weeks. They're known to have a hole in their heart and has a dry cough for 2 days. Listening, they sound like they are wheezing. So investigations we do. So we do an MPA, basically taking a swab of their nose. You do a chest X-ray, which shows that they have hyperinflation. You wouldn't do a chest X-ray normally, but I'm just doing it to add to it. The ABG is this: O2 is 3.5, CO2 is 7.5. They have a low-grade fever. On examination, they have signs of respiratory distress, intercostal recession, nasal flaring, and head bobbing. Then respiratory wheeze. The heart rate is 50, and the respiratory rate is 50. Okay. So, oh no, sorry. Okay, now I'm looking at the time, so I'm going to go forward. But basically, this is bronchiolitis. So bronchiolitis is basically very, very common. A lot of babies come with bronchiolitis. Very common. It's basically your common colds which get down and block off the small air passages. 80% of the time it's respiratory syncytial virus, and normally maternal IgG from the mother, which remember IgG across the placenta, protects the newborn. But once they get to 1 to 9 months old, that protection isn't there as much, and that's when they tend to have it. Your very small babies, those are the ones you tend to have bronchiolitis. They get a low-grade fever, and remember, with epiglottitis, it's a high-grade fever. The risk factors are basically anything that's going to stop the lungs from developing as normal. So premature babies, normally the lungs are the last thing to developing in babies when they're in the womb. So that's why you give steroids to mothers when they're going to premature labor. So bronchopulmonary dysplasia is a basically congenital disorder of the lungs. Cystic fibrosis or congenital heart disease, that whole system just isn't working too well. So for management, basically, if it's mild, pain relief and review. If it's severe, if they're really struggling to breathe, you're going to get them on nasal CPAP. Remember, this is a virus, so we can't give antibiotics. NG feeds and fluids, and also can use ipratropium, but no salbutamol less than 1-year-olds. So just remember. If it's respiratory failure or apnea, they need to ventilate. But majority of the time, this is mild. Now, reasons for omitting you need to know are important. If they have increased respiratory rate above 70 and they have real signs of respiratory distress, such as recessions, grunting, and central cyanosis, so I don't know why that's less than, I don't know why it says there, but basically that's immediate. They need to come in. You consider it if their respiratory rate is up above 60 and they're not feeding well and they're not dehydrated, because they may need resuscitation with fluids and feed. Okay, You need to make sure these babies are feeding properly. The reason is that because they have this obstruction in their small airways, as I said with the head bobbing, when they go to breastfeed, they're unable to do so because they just can't breathe. So they head bob back and forward, and they're not getting a sufficient amount of food in. So, complications. A few things to remember, not that important. Apnea. These patients could require ventilated intubation if not treated. Long-term, chronically, this can cause bronchiolitis obliterans. Basically, you get a lung defect from chronic inflammation. And also hyponatremia, so these patients could have seizures. You prevent this by giving it to high-risk babies. Basically, anyone born premature or congenital heart disease can give a monoclonal antibody, like Trump has, to high-risk babies, and that should hopefully protect them. But it's very common. A lot of babies come in. This is the most common thing I saw when I was on Peds A&E, was bronchiolitis. So, a little summary. Lower airway, we're done. 0 months to 12 months, bronchiolitis, airway obstruction from mucus. Once you get above 12 months to 5 years, normally it's a viral wheeze, okay? And that's because of muscle spasms, and that's causing the airway to obstruct. 5 years above, asthma, muscular spasms. Cool. Oh, my throat is very raw. Okay. The final case. 11-month-old child. Go on, sorry.
Before we go on to the final case, wait, can I just mention 2 things? So one, ABGs. Just remember that in an ABG, when the pediatrician means ABG, what they actually do is like a capillary blood gas.
Yeah.
Because we don't stick needles into the radials of kids. So if you every time you see ABG in pediatrics, in your head, just think of a capillary blood gas instead, or a CBG. Also, before we get on to the last case, can I just give everyone a feedback form to fill out? It's just like, because we've kind of split stuff into mod A, mod B, mod C. There's fewer people at each of them, so we kind of need more of the smaller groups to fill out feedback, just so we know what we need to change. Sorry.
Yeah, that'd be really helpful, guys. Thank you. Cool. So the final case. This is an 11-month-old child brought in by ambulance, and they've been coughing and vomiting. Okay. So 11-month-old child, they had a normal birth. They're not up to date on any vaccinations because mother does not believe in them. She's very much against them. They've been coughing for 2 weeks, which is worse than night, and they go in odd colour, red and blue, when coughing. They vomited this morning after a bout of coughing, and then there's mucus running from their nose and mouth. As you examine the child, they go limp and their SATs full. On examination, they have a clear chest with no added sounds. Okay. Are people, first of all, are they worried about this child? They think that, this is the way I always think. Are they in up shit's creek or are they fine? And that really helps me. But are people worried about this child? Also, I realized I've written an 11-month-old child, which makes no sense. Good. Yes, that's falling. Very worried. Okay. Anyone else worried? Or is anyone not worried? It's absolutely fine to be not worried. This could just be them just having a temper tantrum. Okay. So, I am with you. I am worried. The reason I'm worried is as you said, is that the SATs are falling. And the reason that their SATs are falling is they're having these like hypoxic attacks, is what they're called, because they're coughing so much that they come hypoxemic, they stop breathing, and it's actually terrifying. So I saw a baby exactly like this, and you see their SATs in real time because they were coming to A&E and they had a SATs probe on them, and their SATs are fine. They're like 95, 90, 94, and then they just drop. It's like 82, and then they recover. So these are the investigations we did. We did a swab of their nose. We took their O2 sats. The full blood count was a lymphocytosis, so high levels of white blood cells. And they keep having these falling sats and then recovering. So does anyone know what could be happening to this patient? What does anyone think could be the most likely diagnosis here? No wrong answers. Okay, pertussis. Anyone got any other ideas? Okay, so good. So can I get a whoop whoop? This is whooping cough, otherwise known as bordetella pertussis. You get this whoop because they have this whooping cough, but they have this real apneic attack where these small babies' sats just completely full. They cough so much, which is really sad, that they can burst blood vessels. They can get epistaxis and they can get subconjunctival hemorrhage to the redness in the eyes. And also, you can get this increased white cell count. You see, it's a notifiable disease. Everyone's vaccinated against it, and it's not nice. Management: basically, you admit and isolate. You give all erythromycin or zithromycin within 21 days of symptom onset, but it does not help symptoms. Give everyone in close contact erythromycin prophylaxis. Vaccinate any unvaccinated infant contacts. This is important. School exclusion for 2 days after antibiotics or 21 days after start. Complications: pneumonia, convulsions, brain damage, rib fracture, and significant mortality. It's really, these babies are sick. And they're coughing so much they can really damage themselves by bursting bubbles and fracturing their ribs, actually, just from the effort. Every child should get vaccinated at 8, 12, 16 weeks and preschool, and all pregnant women are vaccinated in each pregnancy, 28 to 36 weeks, regardless of pregnancy. Final question: what other vaccination should all pregnant women get, even though this is a pediatrics and not an obs-and-gynae? So one's pertussis. Does anyone know what the other one is? This is kind of rogue. Sorry. Definitely not respiratory pediatrics. Oh, it is kind of. That's a clue. So it's one you guys should all be having in the moment. It's your flu jab. So each pregnant woman should also get their flu jab. Anyway, that's it. So thank you all. That's it. I think Anush put the slides up in the chat, so you want to go through them again. Anyone ask me any questions now or offline or whatever, I really don't mind. Has anyone got any questions about anything? Cool. Nice. Okay. Well, enjoy, guys. These are the most common things that I see in pediatrics. Definitely was bronchiolitis, and I saw one pertussis as well. So, but the majority of times bronchiolitis. But never forget your ill patients. Okay. Thanks, everyone. Thanks, Anush.
Cheers, Jay. Cool. See you soon.
See you soon, mate.
Bye.